So the question comes to our mind that why to implant toric IOLs in pediatric population. So as Dr. Rajesh told rightly that astigmatism is very common in adult age group, and similarly the children who present to us with the pediatric cases, they have a significant number of children, they have concomitant astigmatism. And as we all know from our experience that once you do a pediatric cataract surgery, you implant the lens, one of the major challenges which is faced by most of us is the management of amblyopia in these young children. So if you implant toric lens in children, then perhaps the management of amblyopia becomes much more easier in these cases, because most of the time these children they don't use glasses, or it's difficult to use a contact lens for providing them uncorrected distant visual acuity. So toric lenses can be very good option in children. In our experience of 50 children, most of the cases we did after 8 years of age, because in younger children reference marking becomes very difficult, and we have youngest child of 6 years of age, but in majority of cases we did toric lens implantation after 8 years of age. And secondly, lens power calculation becomes difficult, and as we all know that the surgical technique in pediatric cataract cases is difficult to do rhexis because of the elastic capsule. The posterior capsule management is very important, because most of the children they present to us with the 100% posterior capsule opacity. So either YARC laser capsulotomy or surgical capsulotomy with anterior vitrectomy may be essential in these cases. And most of the children, the incisions they require suturing, so it can also alter the results or outcome of toric lenses. And in post-op follow-up period, of course, we have to pay attention on the management of amblyopia therapy, and the changing refractive error, because refraction keep on changing. So we have to pay attention on these while planning for toric IOL implantation in children. So the most important pearl is it's important in pediatric cases to mark the principal axis of the eye clearly before surgery, because after general anesthesia there is cyclotorsion and the eye may not be in its normal position. So Dr. Harsul has shown the beautiful way of marking the eye. So in pediatric cases, it's very important that you take child in confidence and just mark the principal visual axis. And while using the slit lamp technique which Dr. Harsul beautifully showed, I used that you can use the green light of the slit lamp. It minimize the photophobia associated with bright light, and you can use the technique of slit lamp marking for reference mark. So marking the principal axis very well preoperatively is the greatest pearl for using toric lenses in pediatric cataract surgery. So it's very important. And as discussed before, that you can practice toric before you go for toric IOLs. You can practice in adult eyes, and those cases with normal cataract, you can practice marking, and you can practice reference marking as well as axis marking in normal cases before you plan for pediatric cases. So it's very important that you practice before you go for pediatric cases. So our youngest case was 6-year-old child with the general cataract, and in this case the pre-op cylinder was 1.5 diopter, and we used Acrisoft toric lens T3 model, and the visual outcome is excellent. Like he regained vision of 6/9 unaided, and so far after 3 years of follow-up there is no PCO. So he maintains the clear visual axis. We have not done the primary posterior capsulotomy in this case, because once you do a primary posterior capsulotomy, then it's difficult to remove the viscoelastic behind the lens. So in all cases, we have not done any posterior capsulotomy, as well as we did not do suturing as well. So this is the toric lens implantation in 6-year-old child. This is another case of anterior lenticonus, 15-year-old child who presented to us with the corneal astigmatism of 2.5 diopter, and because of the lenticonus, he has lenticonus as well as corneal astigmatism. So visual acuity was very poor, and in lenticonus, the lens capsule is very thin and friable. So the important thing is, to perform the rhexis carefully because the capsule is very thin. So sometimes the capsular rhexis becomes very difficult in these cases. So once you do capsular rhexis, these cases are very soft lens. So you can just use bimanual irrigation aspiration to aspirate the lens matter. And once you aspirate the lens matter, you can remove the cortex and then implant the toric lens. And multifocal toric lens can also be good option in unilateral cataract cases. This is a 10-year-old child who presented to us with the posterior subcapsular cataract, and in this case the cataract was unilateral. So we decided to implant a multifocal toric lens in this case. And after marking the eye, we did capsular rhexis and hydrodissection, followed by implantation of multifocal toric lens. And the visual outcome is very good in these cases. So most of these cases are done in general anesthesia. So make sure that you mark, and the marks should not fade away. Otherwise, sometime once the child is taken for GA, so it's very good to scratch the epithelium, and then you can just put the mark so that the mark remains there. So this is the multifocal toric lens implantation. And this is another case which we did almost 2 years back. At that time, the toric and multifocal toric lenses were not available beyond 30 diopter. Now the companies are making up to 30 diopter also. So this case came to us, and he was very keen for independence from glasses. So the corneal astigmatism was 1.5 diopter, and the lens power was coming 35 diopter. So what we did in this case, that we implanted toric lens first in the bag. The power of the toric lens was 20 diopter, and then the multifocal lens was implanted in the bag in a piggyback manner. And after few weeks after surgery, we did YAG laser anterior capsulotomy, cruciate incision to enlarge the capsular opening in order to avoid the interlenticular opacity. And so this child regained 6/6 and 6/9 and N6 vision after piggyback implantation of toric and multifocal lens. And this is another video which I would like to show. This is a 12-year-old child of jonular cataract, and once we did his first eye, because of amblyopia, his vision was 6/36 and N12, and so that we planned for the toric lens in other eye, and fortunately in the other eye the visual acuity regained to 6/6, and with the addition of a 2.5 diopter near it, he regained N6 vision. So what we did in this case, that after 8 weeks after first surgery, which is shown on the top, we implanted Sulcoflex multifocal lens and in a secondary piggyback manner. So the first we did, we removed the cataract, and after 8 weeks after surgery, we just implanted the multifocal Sulcoflex lens from Renner. And this is very good design, and for secondary piggyback lens implantation, you can correct the astigmatism, and you can also it's available in Sulcoflex toric or Sulcoflex multifocal design. So this lens can be helpful to regain good visual outcome after primary surgery. So in summary, we now have toric and multifocal toric lenses as well as Sulcoflex lenses are available, and those cases like younger children and pediatric age group can also get benefited from these premium IOLs. Thank you so much.